Good morning, this is Jason Thompson with Emergency Products and Research. I am producing one of my classic hotel room videos for you. This one is going to be actually regarding the Optimum Traction Device, or the OTD. One of the things I want to go over today is neurovascular assessment, and then also some quick pointers on the use of the OTD in general. So what we're going to start out with is we're going to assume, obviously, that we have a suspected mid-shaft fracture. We're utilizing the simulated traction splint trainer today, which is critical because for repeated examination and practicing, it's best to use something like this because you're not going to risk injury to your patient actors. So it's a much better learning tool, and it can tolerate laying in the same place all day long. And you can actually put this in some pretty compromised positions too, to kind of improve your training program, where it may actually be very uncomfortable for, again, a patient actor to do. So we'll be taking advantage of this. The traction splint trainer allows you to actually simulate up to 250 pounds of traction force with a 250-pound patient, so you can simulate the required traction force to reduce the fracture. So what we're going to kind of start with today is, again, it's a neurovascular assessment. A lot of people are already familiar with this, but I do not want to assume anything. It's always good to just kind of go over it again. So as we're doing a neurovascular assessment on a lower limb, what we're going to do is we're going to assess peripheral circulation, assess peripheral neurologic integrity. So one of the things that we're going to do is, as we go through this, it's important to understand that neurovascular impairment is usually caused by pressure on the nerve or altered vascular supply to the extremity. So if we have some kind of injury up here, that's really kind of where you got to think about. We have some type of impairment, right? So pressure on the nerve. We could have some kind of compromise in the vascular flow, whether that's arterially or that's venously. So we have those are all things we need to think about. So we need to think about the understanding mechanics. So for those who've seen the videos or been involved in my trainings, you'll see that as a femur is generally, this is how it is, and then you get the fracture, and sometimes it can be displaced, right? So all of the veins or arteries that typically flow along or around the femur are now compromised, right? So you take a stick, right, off a tree, a nice healthy stick, and it has the bark around it, and you fracture that stick, and then take it and kind of move it around. You'll see the bark is kind of flexing around with that stick. It's the same kind of thing. So you have all of basically physiology of the femur itself, everything that's shrouding the bone to protect it, all the muscles, including then obviously your nerves, your veins and your arteries, and all the capillaries and everything else. So we have to think about how those are compromised or impaired. One of the big things to understand why that's critical is that delayed recognition of neurovascular compromise can result in permanent muscle and nerve damage, right? So when we think about this, like, why are we reducing a femur fracture? Why are we spending the time considering traction? Again, it's because if we don't take time to do a neurovascular assessment and correct the impairment, that the patient is going to most likely suffer permanent muscle and nerve damage. Now, once we have the traction in place, how often are we going to splinting in place? How often are we going to reassess? Well, we're going to do it no less than every hour. So, if you feel better and the conditions allow, if you can do it every 15 minutes, every half hour, I would encourage you to do that. Let's see. So let's first look at the peroneal nerve. So to basically do the evaluation of the peroneal nerve, we're going to actually look between the toe, right? So we have the greater toe and the next toe over, and basically we're going to look in here into the webbing, and we're going to actually kind of pinch on that to see whether or not they're able to tell us whether they feel that or not. So to see whether there's any perineal nerve damage. And then also we want to do is have them, you know, basically dorsiflex the ankle, you know, extend the toes at the metatarsal phalangeal joint. So, you know, can they extend those? Can they flex it? So we're doing that. The next thing we're going to do is assess the tibial nerve, and basically we'll look at the lateral and medial surfaces of the sole of the foot. So we're going to go up here, and we're going to kind of, you know, come in here. Can you feel me? Right? Can you feel that? You know, can you feel that? Sorry if it's sometimes it's hard to tell what I'm looking at here. So so we're going to raise that up here, and fix my camera angle for you. So, you know, this is, you know, so obviously, so medial, lateral, right? So we're going to check this out. Can they feel this? Can they feel that? And then obviously to assess the tibial nerve, we're going to basically can they plantar flex the ankle and toes. So we're going to have them just basically see if they can flex that back and flex it forward. All right, so that's kind of your basic assessment. The next thing we're going to do is we're going to, you know, that was an active, utilizing active movement assessment, where they're actually voluntarily extending and flexing the extremities or digits. If there's any problems with them being able to do it, we can also do it passively, which is basically us doing the extension or the flexion. And then we want to think about is we talk about the impairment. The big thing we're really looking at here is obviously to prevent the onset of compartment syndrome. And compartment syndrome can show up quickly, but it actually by the time they actually know what's going on, it's typically can be in the really late stages. So we can actually utilize some things to really kind of identify whether or not they're at risk for it. So some considerations: is the pain level out of proportion to the injury? You know, those are kind of things we think about. So, you know, if you suffer that injury, is this relative? Is the pain that they're experiencing or they're articulating to you or expressing to you, is that out of level, out of proportion with what you would expect? The increasing need for analgesics is an indication of possible compartment syndrome. So again, you know, we're not going to tell you that you shouldn't be using analgesics. Again, it goes back to protocol, but you know, again, you have to be really careful that you're not going to mask the compartment syndrome symptoms. So, and you know, if analgesia is just not working for them, you really have to really suspect that you have compartment syndrome going on to some level. So the biggest thing is that, you know, in addition to that is, you know, what is the adequacy of the arterial supply and the venous return? And, you know, we can assess that a couple of different ways. So what I'm going to show you here is we're going to look at the foot, and we're going to see is the lower extremity, you know, what's the color? If there is an inadequate arterial supply, it's going to be pale or white. If there's an inadequate venous return, it's going to be blue or mottled. The temperature, if there's inadequate arterial supply, will be cool to the touch. If there's inadequate venous return, it's going to be hot to the touch. Refill for inadequate arterial supply is going to be greater than 2 seconds. So basically going to just kind of see here on the toes, you know, what is our capillary refill? If it's greater than 2 seconds, we should suspect inadequate arterial supply. If it's immediate, maybe inadequate venous return. What about the swelling? If the extremity, everything seems to be hollow or prune-like, we may want to suspect inadequate arterial supply. And if it feels swollen, the tissues feel very hard to the touch, we may want to think about inadequate venous return. So the understanding compartment syndrome. So compartment syndrome is an increase of pressure within a muscle compartment caused by an increase in interstitial pressure within the osseofacial compartments. So essentially is in these each of these muscle segments, large muscle segments and smaller muscle segments, all have compartments. And as the you know, typically we have arterial flow, which flows away from the heart down to the tip of the toes, and then it returns through venous supply back to the heart, right? So if there's some type of impairment, you know, let's say that the highway, right, this big flood comes through this interstate and it washes it's away, you know, all these people have come onto this island, right, and they're over there, but they can't go anywhere, but they need to go. Let's say that the southbound lane is still open, so people will keep coming in, but there's only so many people who can fit on that island, but they keep coming and keep coming and keep coming. Obviously, eventually it's going to cause a problem. So until they're able to restore the northbound traffic, you know, and all these southbound keeps coming, it's going to be a problem. So what we want to try and do is restore that northbound traffic, if you will. That's one thing. There's also the fact that the venous supply could still be, you know, pumping out, but for some reason there's some type of arterial. So the southbound lanes could be shut down, but the northbound lanes are still open. So vice versa. So anyway, and as far as the nerves, you know, obviously there's communication between the brain and the toes, and if that's interrupted, you know, that's going to cause some problems for them too. So anyway, I won't get into more detail than that. It's already well into this, longer than I want it to be. But the next thing we want to look at is basically, I'm just going through some of these notes I jotted down before I started the video. But if pressure is not relieved, necrosis of the soft tissues will occur, leading to permanent contracture deformities. Basically is, again, compartment syndrome is not relieved by simple analgesics, non-narcotics, and excessive pain and passive extension flexion. So those are some indicators. Narcotics can mask the pain from compartment syndrome. This should not preclude appropriate analgesia. If tolerable and appropriate, raise the limb above the level of the heart. Peripheral nerve injury can be caused by the fracture, stretching or severing a nerve or nerves. Vascular injuries can be caused by severely displaced fractures. And then ischemic limbs associated with fractures require immediate closed reduction to remove tension on the neurovascular structures. Usually circulation to the limb is restored. So that's extremely important. I'm going to say it again. This is kind of really where we're at here, right? So ischemic limbs associated with fractures require immediate closed reduction to remove tension of the neurovascular structures. Usually circulation of the limb is restored. So again, understanding that is, what are we trying to do here? Traction, right? So we have a displaced fracture. We're trying to reduce that fracture and stabilize that fracture so that we can get them to the hospital and they can actually do interventional things to actually to close that up and stabilize it with pins, plates, whatever it may be, in a hospital setting that cannot be done in a pre-hospital setting. So that's really kind of what we're thinking about here. All right, so with that, I want to go into this real quick, and again, we'll cut these videos down later, but I just want to kind of get the raw content out there because we have a number of folks who are asking a lot of really good questions and they need immediate direction. So these videos tend to be a great resource for that, and they're kind of enable me to address a lot of issues to a lot of people on the fly. And as you know, that's critical. Force multiplication, right?